Okay, welcome to Anatomy of the Biliary Tract and Upper Gastrointestinal System. Specifically, this lecture will discuss the liver, gallbladder, and biliary tract. Now, let's get started. So, imaging of the biliary system involves studying the manufacture, transportation, and storage of bile. Now remember, bile is made in the liver. It's transported by various ducts and stored in the gallbladder. The liver is the largest solid organ in the human body and weighs between 3 to 4 pounds in an average patient. So in an average adult, the liver makes up 1/36th of your total body weight. So it's a pretty significant organ. The liver lives primarily in the right upper quadrant, but if you were to divide the abdomen into the 9 regions that we learned last semester, if you think about those 9 abdominal regions, the liver occupies almost all of the right hypochondrium, a major part of the epigastrum, and a significant part of the left hypochondrium. And then just on the slide here, notice how this is pointing out the right hemidiaphragm. Remember, hemidiaphragm is referring to half of the diaphragm. So the liver, you can see, primarily is housed under the right hemidiaphragm, but it does peek over to the left a little bit. All right, so liver and gallbladder. Now the liver is a triangular organ, so its shape is triangular. Now the superior border is the widest portion of the liver. So this right here, the widest part of the liver, it's approximately 8 to 9 inches long. And it's convex to meet with the inferior surface of the diaphragm, which we just talked about in the previous slide. Now the right-hand border of the liver is the greatest in vertical dimension. So on this border right here, it's approximately 6 to 7 inches long. Now in an average person, the right-hand side of the liver extends from the diaphragm to just below the body of the 10th rib. So here at the top would be diaphragm, right? And then down here, this would be about the 10th rib. Now the liver is a very vascular organ, meaning there's lots of blood vessels, and it's easily lacerated in a trauma. So protection by the ribs is very, very important. Now the gallbladder is typically nestled centrally, okay, so kind of midline, in the posterior inferior region of the liver. So posterior, inferior, but centrally located. So kind of in between or in the middle of the liver from right to left, and then inferior and posterior. All right. The distal end of the gallbladder extends slightly below the bottom of the liver. So here's the bottom of the liver, and here's your gallbladder peeking out. Now, the gallbladder, or excuse me, rather the liver, is partially divided into 2 major lobes and 2 minor lobes. Only the 2 major lobes can be seen from the anterior perspective. Now, the much larger right lobe, which we see here, is separated from the smaller left lobe by this falciform ligament. And you can see the falciform ligament here in the back as well. So that ligament runs through and divides these lobes of the liver. Now, the 2 minor lobes of the liver can be found on the posterior aspect of the right lobe. So they are found to the right of the falciform ligament. The quadrate lobe is located on the inferior surface of the right lobe between the gallbladder and the falciform ligament. Just posterior to the quadrate lobe, or just behind the quadrate lobe, is the caudate lobe, which extends superiorly all the way to the diaphragm. Now this diagram doesn't really demonstrate that very nicely, but what I'm saying is the caudate lobe is actually located posterior, a little bit behind the quadrate lobe, which isn't a big deal, not a huge detail for you to remember, but just for your information. So the caudate lobe is superior and posterior. The quadrate lobe is inferior and more anterior to the caudate lobe. Okay. All right. The very large inferior vena cava, which is this huge blood vessel right here, contours over the surface of the caudate lobe. The mid-inferior surface, okay, so mid-inferior right here, includes the hepatic bile ducts, which we're going to discuss in a little bit. Okay. Now, the liver actually performs more than 100 different functions, but the function that's most important for our purposes is the production of large amounts of bile. So the liver secretes 800 to 1,000 milliliters of bile per day. That is about 1 quart of bile each and every day. The major function of bile is to aid in the digestion of fats by breaking down or emulsifying fat globules and in the absorption of fat following its digestion. So the liver makes bile, it's stored in the gallbladder, and then it helps to break down fat in the foods that we eat. Now let's talk about bile and how it travels from the liver to the gallbladder. Now bile is formed in the liver, like we said, in these small little lobules. And it travels via small ducts to the larger right or left hepatic duct. So imagine the liver is sitting right up here. Just kind of draw that in with your mind or draw it on your PowerPoint. So bile is made in the liver in these little tiny lobules, and then it travels via these really small ducts, and it eventually makes it to the right and left hepatic duct. Right or left, I should say. Now, the right and left hepatic ducts join to make the common hepatic duct, which is seen right here. So bile is carried in one of the right or left hepatic ducts down the common hepatic duct, and then it enters the cystic duct, which is this little duct here, I guess you'd say. Now, it enters the gallbladder for storage purposes only. So if the bile can be used, it will travel immediately down into the duodenum, but we'll talk about that in just a second. If it's following the cystic duct into the gallbladder, that is for temporary storage. Now, let's say that we've eaten some fatty foods, we don't have enough bile stored in our gallbladder, so we're going to release bile directly from the liver. Same thing, it's going to leave the lobules, go into the right or left hepatic duct, meet in the common hepatic duct, and rather than taking a turn into the cystic duct, it's going to continue down into the common bile duct, where it then advances into the duodenum. And once bile reaches the duodenum, that's how it helps break down our fatty foods. Now the common bile duct, distally, so down here, is joined by the pancreatic duct, or the duct of Versong. I know it says Wirsung, but it's Versong. Where they meet is known as the hepatopancreatic sphincter. Okay? And that, we'll talk about that in a couple slides, so don't worry about writing that right now. Anyways, where these two meet up, the common bile duct and the pancreatic duct, they meet up and they empty into the duodenum. Okay, so once bile leaves the liver, it's either going into the gallbladder or directly out through the common bile duct into the duodenum, where it will help emulsify fats. Now let's talk about the gallbladder for a second. It looks a lot like a pear, don't you think? It's kind of a pear-shaped structure, and it's made up of 3 different parts. So you have the fundus, which is most distal, you have the body in the middle, and then you have the neck, which is the most proximal or yeah, proximal is a good word, the most proximal aspect of the gallbladder. Now, the fundus, at the fundus, that's the broadest part of the gallbladder. The body is the main section, and again, the neck is that narrow little proximal end that continues into the cystic duct. So this whole thing is the cystic duct. And remember that kind of meets up that common hepatic duct, and then below that becomes the common bile duct. Now, the cystic duct is 3 to 4 centimeters long. So this right here, 3 to 4 centimeters long, and contains several folds made up of membranes. So they call it membranous folds, membranous folds. These folds are called the spiral valves. They function to prevent distension or collapse of the cystic duct. So they just kind of keep everything normal. They don't want the cystic duct getting too big. They don't want the cystic duct getting too small. The normal gallbladder is 7 to 10 centimeters long and approximately 3 centimeters wide. It generally holds between 30 and 40 milliliters of bile. Now remember, the liver produces between 800 and 1,000 milliliters of bile every day. So let's talk about the functions of the gallbladder. Now remember, the liver has over 100 different functions. The gallbladder only has 3 primary functions. Number 1, storage of bile. Number 2, concentrate bile. And number 3, contract when stimulated. So let's talk about those in a little more detail. Storage of bile, number 1. If bile is not needed for digestive purposes, it's stored for future use in the gallbladder. Okay, so it's like a little purse. It's holding your bile. It's your bile purse. Number 2, concentration of bile. Bile is concentrated within the gallbladder as a result of hydrolysis. Do you remember what hydrolysis means? That's the removal of water. Now, in an abnormal situation, when too much water is absorbed, or when the cholesterol, which is found within bile, becomes too concentrated, gallstones may form in the gallbladder. Another word for gallstones is choleliths. Chole referring to gallbladder, lith referring to a calcification or a stone. Now, cholesterol in the bile is the most common cause for gallstones. In fact, in my notes I have cholesterol forms the most common type of gallstone. All right. So what that's saying is that typically what's causing the most gallstones is when there's too much concentration of cholesterol in the bile, not necessarily too much absorption of water. All right, number 3, contraction when stimulated. Now the gallbladder normally contracts when foods such as fats or fatty acids are in the duodenum. These foods, so like if you eat McDonald's, for example, let's just pick on them. When you eat that kind of food, your duodenum is stimulated to secrete a hormone called cholecystokinin. Cholecystokinin, and it's here, I'm probably not pronouncing it right, but you can abbreviate it CCK. So fatty foods stimulate the mucosa of the duodenum to secrete CCK. Now, increased levels of CCK in the blood cause the gallbladder to contract and the terminal opening of the common bile duct to relax. So all I'm saying there is this area of the common bile duct will relax. That allows bile to pass into the duodenum. Now, CCK also causes increased exocrine activity by the pancreas, which isn't a huge deal for you to know, but just a little fact for you. Now, let's break this down and make this a little easier. When you eat fatty foods, the duodenum releases the hormone CCK, and the gallbladder is therefore stimulated to contract and release bile to help emulsify the fats. Let's talk about the distal common bile duct. Now, the common bile duct is about 7.5 centimeters in length. So now I'm talking about this tube right here. Remember, if you follow this tube up, you'll meet the cystic duct on this side, and you'll meet the common hepatic duct up further. All right, so it's about 7.5 centimeters in length and has an internal diameter the size of a drinking straw. So you can think of this as a straw. Now the common bile duct descends, now you can abbreviate that CBD, by the way, common bile duct. It descends behind the superior portion of the duodenum and the head of the pancreas, and it enters into the descending portion of the duodenum. So let's back up one slide to take a peek at that. Oopsie, that's not the right slide. I'll show that to you in a bit. Just hang on with that thought. In other words, the common bile duct does not enter right away at the duodenum where it meets with the stomach. It enters further down at what's known as the descending duodenum. And I will point that out to you. Now, in 60% of people, the end of the common bile duct meets up with the end of the pancreatic duct, which is here, and they form together one common passageway into the duodenum, and that's the hepatopancreatic ampulla. Okay, so this is a drawing of 60% of people. The common bile duct meets with the pancreatic duct, and they form one little highway here known as the hepatopancreatic ampulla. Now, in these 60% of people, this short little channel, oh brother, right here, this short little channel becomes narrower and narrower as it enters the duodenum, and that's therefore a very common site for impaction of gallstones. Now, the remaining 40% of people will have a separate passageway for the common bile duct and a separate passageway for the pancreatic duct, and so there'll be two separate openings which pass into the duodenum. Okay? Now, near the end of the common bile duct, which again is down here, the wall of the duct contains these little circular muscle fibers, and those are known as the hepatopancreatic sphincters, or sphincters of Oddi. The sphincters relax when the levels of CCK increase in the bloodstream. And remember, that makes sense. If there's increased fatty foods in our body, so we eat McDonald's, the duodenum is going to release CCK, which makes our gallbladder contract, releasing bile to help emulsify those fats. And then if bile's been released, we need this opening to open so that the bile can come down the common bile duct into the duodenum to help out with those fats. So when there's increased levels of CCK, not only is the gallbladder contracting, but the hepatopancreatic sphincter is relaxing to allow that bile to enter the duodenum. Now, the presence of those muscles, those hepatopancreatic sphincters, causes a protrusion in the lumen of the duodenum. So basically, there's just this little outpouching here, this little bump in the duodenum, and that's known as the duodenal papilla, or the papilla of Vater. Okay. Notice in this slide, notice the relationship of the liver, the gallbladder, and the biliary ducts. Now, the gallbladder, so let me back up. This is actually a lateral projection of the abdomen. This is anterior, this is posterior. So what I want to point out to you is look at the gallbladder and how anterior it is. So if you drew a line right here, mid-coronal plane, the gallbladder sits anterior. The ductal system is pretty midline, and therefore, if you put the patient in a prone position, the gallbladder is going to be closest to the image receptor, which will give you better detail. Okay? Now, let's say you wanted to drain the gallbladder. You would therefore put the patient into a supine position, so that this cystic duct can drain. Now notice here you've got the common hepatic duct, then the cystic duct, and then farther down it becomes the common bile duct. Now this is the slide that I was talking about where the common bile duct enters the descending aspect of the duodenum. See how this is the C-loop of the duodenum? So the common bile duct crosses over that top part of the duodenum, comes down and enters at the descending aspect of the duodenum. That's what I was talking about in the last slide. So I apologize for getting ahead of myself. All right, let's look at this x-ray. So in this x-ray, the patient has drank oral contrast, and this is what's known as an oral cholecystogram. Now this was done in the olden days, like I always say. This type of exam is no longer performed. Ultrasound is the modality of choice, but we'll talk about that in a second. This patient is in a 35 to 40 degree LAO, and you can tell they're in an oblique because you can look at the spine and see those Scotty dogs, so you know they're in an oblique. Now, that gallbladder is full of ingested radio-opaque contrast media. Let's go through the anatomy. Now, D is pointing to the fundus of the gallbladder. Notice its position too. This is the crest right here. It's sitting low. C is the body of the gallbladder. B is the neck of the gallbladder, and A is the cystic duct. Okay, now again, these type of exams are not done anymore, oral cholecystograms, because ultrasound is the modality of choice, and let's talk about that in the next slide. So here is an ultrasound of the gallbladder. So anything gray here, this would be the liver, and then you'd have fat and muscle, and then this gallbladder right here is empty. Patients, when they're having a gallbladder ultrasound, should be NPO for 8 hours prior. So that means there should be nothing to eat or drink by mouth for 8 hours prior. That will ensure that the gallbladder is empty. There's no bile being stored in there because the patient hasn't eaten. Now, ultrasound offers 4 different advantages over the oral cholecystogram that you saw in the last slide. Number 1, there's no radiation for our patients. So right there, that's awesome. Number 2, in an ultrasound of the gallbladder, you're going to see small stones, like a small gallstone. Remember, those are called choleliths. You'll see a small stone that might be missed on an x-ray. Number 3, the patient doesn't have to drink any contrast. So that's nice, especially for people that are sensitive to contrast or have allergies to certain types of contrast. And number 4, there's less patient prep. So again, for an ultrasound, patients have to be NPO for 8 hours, but if you're doing an oral cholecystogram, those patients needed a 2-day prep. So that's, they're not eating, they're drinking thin liquids, perhaps they're doing some type of bowel cleansing. They don't want any gas or bowel overlying the gallbladder. So quite an extensive prep. So again, for ultrasound, NPO for 8 hours. Also, ultrasound provides a quick diagnosis for patients, and physicians can make surgical decisions within hours rather than waiting days for the oral cholecystogram. So pretty cool stuff. We're going to talk about this in class a little bit, but if you have any questions before then, please let me know. Thank you.